Good morning, everyone. Thanks very much to Roy for the introduction and to you for coming to this very important event. As Roy says, my name's Alex Stevens. I'm a criminologist, but I chaired the group of the Advisory Council of the Misuse of Drugs, which has a responsibility UK-wide to advise ministers on how to reduce harm. I chaired that group's work on reducing opioid-related deaths in the UK. Building on work done by the Office of National Statistics, National Records in Scotland, and specifically very useful work by the Scottish Drug Forum and the Scottish National Forum on Reducing Drug-Related Deaths. We were of the opinion last spring that there was a huge problem with drug-related deaths and the government was not doing enough about it, and we hoped that by focusing ministers' attention through the work of the ACMD, we would be able to inspire at least some more reflection on how we can prevent these preventable deaths. But I should warn you that I'm not speaking for the ACMD, only the chair of the ACMD can do that, so the comments that I make today should be taken as reflecting my personal capacities, even though I'd like to thank my colleagues who worked on the report with me who are named here. What I'll be talking about is what's our understanding of the causes of these deaths. We know that we have record numbers of drug-related deaths, not just in Scotland, but in the three other countries of the United Kingdom. There are record levels in England, record levels in Wales, record levels in Northern Ireland. What's going on? What's causing this? And therefore, what can we do about it? What are the effective responses that we identified and recommended to the government? And I'll talk a bit about how the Westminster government responded to those recommendations as well, before I conclude on what we can hope to achieve in preventing these preventable deaths. Now, as Roy has suggested, one of the main causes that's been identified for the increase in drug-related deaths has been to do with the cohort effect of a prematurely aging group of drug users who started drug use back in the 80s and 90s and become more vulnerable as they age. And I'll look a bit more in detail at that and talk a bit more about why that shouldn't be an excuse for inaction as it has often been. But I also want to draw our attention to some of the other causes that we've identified as potentially contributing. We obviously can't randomise people and do experimental studies here, so we're in the realm of observational research where we identify potential causes rather than being able to prove them. But we can think about changes in the availability of heroin and its purity. We can think about changes in the commissioning and provision of treatment as potentially contributing to increases in deaths. And we should also think about the socioeconomic circumstances within which people are aging and choosing to use substances which might kill them. So let's look at this age effect. Here you see a graph from England. I'll show you one from Scotland in a minute, which shows you the numbers, I think it's here. No, these are the rates, sorry, per million of deaths at different age groups. And there is some good news on this graph in that we see the orange line. There's a historical line here. There's a historical reduction in the number of young people, people in their 20s, who are dying of deaths that are recorded as being drug-related. And we see a much larger increase in the groups over 40, and the majority in England of people who die of drug-related deaths are now over 40. So this is the reason, one of the reasons why this increase in deaths is being attributed to the fact we have this aging cohort. But I think there's two things I'd like to say about that. One is the same as what Roy's just said. Just because we are all aging doesn't mean that we should accept that some of us have to die in our 40s just because of what we started doing in our 20s. These deaths can be reduced, and the fact that it's harder to do so amongst people whose health is failing because they're older does not mean we should not be trying to help those people avoid death. And also this excuse is starting to wear a bit thin, given that we're starting to see an uptick across the UK in the numbers of young people who are dying. So you see the end of that orange line in the most recent figures released last month. We have an uptick in people in their 20s dying of drug-related deaths. And you'll see that's also true for the Scottish figures. And again, it's the orange line are people in their 20s. And you see a less dramatic reduction amongst the younger age group in Scotland than in England, and a recent increase in the numbers of people in their 20s who who are dying. Now, I haven't had the chance yet to look at what's behind that most recent increase in people in their 20s dying, and whether those are opiates or part of the increase in cocaine deaths, for example, in that age group. But it's certainly another reason not to just put this problem in a cupboard that says it's too difficult, they're old people, they're going to die anyway. We're not going to do that. We're actually going to try and find solutions which we have at our hands to reduce these deaths, no matter how old the person who is vulnerable is. So the other potential cause I'd like to draw your attention to are the changes in availability of heroin. And you'll have heard, no doubt, and some of you may have experienced it personally, the heroin drought of the 2010s, 2012. There's some speculation as to what caused this. Poppy blight in Afghanistan, interruptions on the Balkan route of supply of heroin to the UK, causing a lot of difficulty on the street in getting hold of good quality heroin. And that was indicated by a dramatic reduction in the purity of heroin. Now, some people have said it's the purity that's the problem, but work by Shane Dark and others has suggested that it's not purity that kills people. Purity is an indicator of how easy it is to get hold of heroin. And so if dealers can't get hold of good heroin, they cut it more. And if users can't get hold of good heroin, then they're not less likely to use it and overdose from it. And we see an indication of that, for example, in these English figures, which show that during the heroin drought, there was quite a substantial reduction in the numbers of people who were dying with heroin mentioned on the death certificate. And a slight bump, that's the blue line is heroin, the red line is methadone. And you see a slight bump in the methadone figures as people seem to be switching from heroin that they can't find anymore to methadone that they can, and therefore dying of methadone instead of heroin. If I go back to the Scottish figures, you'll see in the older age groups, the blue and the red line at the top are 25 to 34 and 35 to 44. You do see that slight dip in Scotland around that time as well. But it's not as substantial as England, which makes me wonder about what it is about Scotland that had a smaller effect from the heroin drought than England. Was the heroin drought less pronounced in Scotland than in England, or had treatment already become less protective against drug-related death before, so there was less difference from the availability of heroin? You will know and have your own ideas on that, probably more informed than mine. The other cause I wanted to talk about was socioeconomic deprivation and poverty. These are figures from the Office for National Statistics which divide the rates of death from drug-related causes by the quintile, which group of the 5 most to least deprived communities you live in. And the graph shows across time that the rates of death from drugs are approximately 5 times higher in the most deprived communities to the least deprived communities, and they're also increasing fastest in the most deprived communities. Another way of thinking about that is through maps, and this map may look very familiar to you in that it looks very much like a map of where rates of drug-related deaths are highest across the UK. It's actually a map of where cuts to welfare budgets have been highest. And that maps very closely to where the drug-related deaths are, because it's socially economically deprived communities that experience the greatest cuts in incomes related to welfare cuts. And in England, you'll see that the town that experienced the highest proportional reduction in the incomes of working age adults through welfare reform was Blackpool. Blackpool is also by far and away the town that is most affected by drug-related death. It has a rate of about 130 per million of drug-related deaths, which is about 50 higher than its nearest rival for that title. So we are concentrating reductions in incomes on the communities that are already suffering the most from drug-related deaths and increasingly suffer the most from drug-related deaths. We've also seen cuts to treatment budgets, and I'm less informed about Scotland than many people in this room. but cuts to treatment budgets have been quite severe, certainly in England. And we've seen a lot of changes, not only in the money that's available, but also in the pattern of commissioning. And we've seen a reduction in the length of time that people are commissioned for. And what we see is that performance in drug treatment systems tends to fall when you recommission. It then starts to stabilise and increase as the system gets used to itself again, and then, bang, another recommissioning cycle happens. And so we're damaging the effectiveness of our drug treatment systems by reducing the length of time that each contract lasts. So one of the things that the ACMD is recommending in a report that's just about to come out about the commissioning of drug treatment services is that we should encourage greater stability in the drug treatment system in order not to keep hindering its effectiveness. It's not just the money or the timing, it's also the types of treatment that we are commissioning. So in the wake of the HIV epidemic of the 1980s, which was obviously felt here and in Edinburgh much more severely than in other parts of the country, the ACMD advised the government to invest heavily in harm reduction services and specifically opiate substitution treatments to protect people from HIV infections. And that was very successful in protecting and producing a much lower rate of HIV infection amongst injecting drug users in this country than several of its counterparts. That approach was repudiated in the late 2000s, and the change was earlier in Scotland than it was in England, and we moved to an approach that focused on getting people out of treatment rather than keeping them in treatment. Given that we know that people out of treatment are much more vulnerable to death than people in treatment, and I mean by treatment, I mean opiate substitution treatment, it would be possible to predict that getting more people out of treatment quicker would produce an increase in deaths. And that is what we have seen. And there's interesting observational qualitative research being done on how it not only changes the commissioning, it changes the attitudes of treatment staff. So Faye Dennis, for example, in her PhD project found drug treatment workers thinking of harm reduction as almost a quaint, outdated practice. People saying we only do reduction, we don't do maintenance anymore. That's not a valid goal of drug treatment. That is a dangerous thing for a drug treatment worker to be saying, that maintenance is not valid in itself as a way of protecting people from the risk of death. So these pressures on people to be on a lower script than they need and to finish it earlier than they would otherwise do, that is a dangerous treatment practice that we have recommended should be ended. So we have this problem that we think we can explain using a few factors, and we'd obviously like to have more investment in research to try and beef up and make this more certain. But we do have very good research, much better research than on the causes. We have research on what are effective responses. And these include, I think the top line here is effective opioid substitution treatment of optimal dosage and duration. That is the approach which has and is likely to have in future the biggest impact in reducing drug-related deaths. We have increasing evidence on the effectiveness of naloxone, and we want to keep on expanding the availability of naloxone through giving it not only to practitioners but to peers and family members, by developing intranasal preparations. So part of the reason for developing an intranasal preparation, which these intranasal preparations are available but they're not currently licensed for use in the UK, part of the reason for wanting to develop intranasal preparations is that we would like to get, I hope, to a state where naloxone can be bought over the counter at a chemist. And while it's an injection-only preparation, that is very unlikely to happen. So we need the government to invest and companies to invest in developing licensed intranasal products that can be distributed widely and cheaply to whoever might come across somebody in overdose. I've also talked to a couple of police and crime commissioners about the idea of police officers carrying naloxone routinely, which is already happening in some parts of North America. And I'd like to hear your views on that happening in Scotland. We also have good evidence on heroin-assisted treatment. Wherever the new version of heroin prescription, so not the old British system of physicians prescribing heroin to their patients, but the new Swiss model of heroin-assisted treatment, involving people visiting a clinic daily for supervised injections of prescribed diamorphine. Wherever that's been piloted, it's been shown to be effective in reducing use of street heroin, reducing crime, and protecting the health of people who go through it, including in the 3 pilot clinics in the riot trial in England, which unfortunately were dismantled in 2015 when the central funding was taken away. Local authorities decided it was too expensive an approach for them to keep on funding, so we recommended that there should be national funding for heroin-assisted treatment. And we also recommended that, given the evidence on medically supervised injecting consumption rooms, or drug consumption rooms, depending on what you want to call them, given the evidence of reduced deaths in their immediate vicinity and no deaths within them, and the ability of those centres to identify and prevent death from overdose, that consideration should be given to opening such clinics in locations which have a high concentration of injecting drug use. I'll just give you some of the reasons why we recommended these as the effective responses. Many of you will be familiar with the many systematic reviews that have been done on opiate substitution treatment, based on both experimental studies and large-scale observational cohort studies. The effects we see from the experimental studies include increased engagement, increased retention, reductions in HIV, and reductions in criminal offences. Now, the experimental studies tend to be too small to have the statistical power to identify effects on death. Death, thankfully, is a relatively rare event. So you need a massive sample to identify that effect. But you can't see that effect in experimental studies, but we do see it in some of the observational studies that have looked at large groups of people going through treatment. And we see some extremely dramatic, I think, and successful findings. I think the most interesting one, most sort of standout one that I came across while reviewing this evidence was the fact that in Barcelona, which had quite a rapid increase in opiate substitution treatment in the early 90s, you saw an increase in the life expectancy of heroin users in that city of 21 years in just a couple of years. A dramatic effect in protecting people from dying from heroin overdose. Part of the effect is also shown here in data that was provided to me by Tim Miller. Again, a large cohort study looking at people in and out of treatment. And the blue column on the right is their adjusted hazard. So you look at their risk of death and you adjust that for other factors like their age, their sex, and other things you'll collect information on. And you compare the risk of death of people who are out of treatment compared to in treatment. And you discover that once you adjust for those other risks, people are about 50% more times likely to die if they are out of treatment than if they're in treatment. This is a substantial protective effect of being in opioid substitution treatment. In other studies done on similar data, this effect has only been found for opioid substitution treatment. So there doesn't appear to be a protective effect of being in other forms of treatment against death. So we need to get and retain people who are injecting heroin in opioid substitution treatment of optimal dosage and optimal duration. And we need to make naloxone available to them. Naloxone, again, is very hard. The effects of naloxone are very hard to study experimentally because the risk of death is relatively rare. But those studies that have been done, and there was a review of them by Giglio et al., and it discovered that when people didn't have naloxone available to them, their risk of dying from an overdose event was 8 times higher. And Kirsten Horsburgh will be telling us later about the successful interventions in the naloxone area in Scotland. This is a graph showing some of the effects from those three clinics that were trialled in England. And the indicator here that's being looked at is on the vertical scale, the percentage of participants who became abstinent from street heroin. And the comparison was, there were 3 groups randomized either to injectable heroin, injectable morphine, or optimized oral, injectable methadone, or optimized oral methadone. And you'll see that the group that was able to gain the quickest levels of abstinence from street heroin and to maintain those levels of abstinence was the group that were prescribed injectable heroin. And this is a group, remember, that had previously, this is a group for whom methadone had not previously worked. To be eligible for the trial, you had to have previously tried methadone and it not to have worked for you. So this is a group who are very much the group we want to get to, people who have not been served well by existing methadone maintenance programs, who are at very high risk of death, can be engaged and retained in heroin-assisted treatment. Now, the commissioners, as I heard, at a local level in England said, no, this is too expensive, we can't afford it. And it's true that if you were to look at these costs and ignore the red part of the bar, which is the part associated with crime. So imagine you can't see the red bit. You look at the costs of injectable heroin compared to oral methadone, and you'll see it's a lot more expensive. But oral methadone is a lot less effective with this group than prescribing heroin is, especially when you look at the reductions in crime. And if you take into account the increased reduction in crime you get with this group if you prescribe heroin, then it's actually more expensive to provide oral methadone than it is to provide injectable heroin. The problem being, of course, that this money is not coming out of the budgets of the police, it's coming out of the budgets of health commissioners who have less direct incentive to care about whether people are being victims of crime or that the police are very busy in their neighbourhood. So we need to think about how we're going to shift the money from the crime budget to the health budget in order that cost-effective approaches like heroin-assisted treatment can be supported at local level. In the meanwhile, we need national governments in Westminster and Edinburgh to invest where the crime budget won't. And just to recap on medically supervised injecting centres, they are effective where they operate. The only studies that have been done really come from Sydney and Vancouver. They're much more common in continental Europe, but perhaps because they're much less controversial in continental Europe, there's been much less research collected on their actual effects. But those studies that have been done show these positive effects, but they too tend to be confined to the immediate vicinity of a drug consumption room. So this is not going to be a blanket solution across a nation, but it can be a solution in a locally concentrated place where you see high concentrations of injecting drug use and death, like, unfortunately, Glasgow. Now, when we published this report in December 2016, we did include some information on fentanyl and oxycodone, synthetic opioids that are highly risky, especially fentanyl and its exceptionally strong cousin carfentanil. Since we published the report, we've seen more deaths in England that have been related to fentanyl. And the Home Secretary has asked the ACMD to provide advice on how to reduce fentanyl deaths. My response to the Home Secretary was, we have already told you how to do this. Fentanyl deaths are opioid deaths. We've just given you a report on how to reduce opioid-related deaths. The emergence of fentanyl on the drug-using scene makes the types of measures, the evidence-based measures we know reduce these deaths, even more important and even more urgent to implement. Now, the UK government is supposed to respond to ACMD reports within 3 months. It took them 6 months to respond to this report, and their response was not particularly encouraging. So one of the things we recommended was that there should be more attempts to alleviate the poverty that is associated with drug-related deaths. As you know, the government at the UK level is continuing with welfare cuts that will substantially increase poverty rather than reducing it. Our main recommendation in the report, and we made this very clear that this is the main thing that is going to have the greatest impact, is to maintain and increase investment of opioid substitution treatment of optimal dosage and duration. And the government's response has to be said, yes, we've got new clinical guidance, but we're not going to produce any more money. We're still going to continue cutting funding for this effective response. On naloxone, we've been much slower in England than in Scotland or Northern Ireland to roll out naloxone, and the Westminster government's response has been just to point at what local authorities are doing, rather than having national investment in a national programme to respond to this national epidemic. On heroin-assisted treatment, government has refused to provide central funding for heroin-assisted treatment, despite the problems of it being stopped at local level. The only place where I could possibly claim a small amount of victory in terms of us getting ministers to change their minds on these issues is on drug consumption rooms. In 2013, that was the latest time that a Home Office minister repeated their previous line, which was that drug consumption rooms were illegal. They encouraged drug use and were against both the international conventions and UK law. There's been a slight shift in their position. In their response that they published to our report, they said that we'd got no plans to do it, but if local authority areas want to do it, they're indicating that they're not necessarily going to stand in their way, which is the only silver lining in what I think is a pretty depressing rain-filled cloud of inertia, indifference and inaction from the Westminster government on this national problem. So to conclude, these are preventable deaths. Just because people are getting older and more vulnerable does not mean we shouldn't be trying to do all that we can to prevent these deaths, and we should be getting increasingly worried about young people also seeing increasing rates of drug-related deaths. Especially because it's not as if we don't know how to do this. We have in the UK a long, proud record of introducing and implementing evidence-based services that reduce the levels of drug-related deaths amongst people who have problems with drugs. We can do this if we have the political will to invest and innovate in reducing these deaths. And it is clear now that the Westminster government is not going to be the government that will invest and innovate. So my question for you today is, will Scotland lead the way? Thank you.